Welcome to the deep dive. Today, we're taking a truly specialized look at a medical procedure. It's one that seems deceptively simple in concept, but is incredibly high stakes in execution.
It really is.
And our mission today is driven entirely by the material you shared with us, specifically excerpts from Dr. G.S. Raj's really insightful YouTube discussion.
Yes, the one on pneumatic dilation for achalasia.
Mm-hmm.
That material is, it's practically a masterclass in mechanical gastroenterology.
Exactly. So we're zeroing in on that procedure, pneumatic balloon dilation, focusing on the surprising mechanical differences that set this device apart from, well, pretty much every other type of dilation tool.
Right. And to get there, we really have to start with the problem itself, achalasia.
We have to. Because when we talk about achalasia, we are not talking about simple scar tissue or, a blockage. This is a double muscle failure.
Precisely. Achalasia is fundamentally a motor disturbance of the esophagus. You've got two things happening at once. First, the lower esophageal sphincter, the LES.
That's the little valve at the bottom.
That's the one. That muscular valve is spastic. It just doesn't relax when you swallow, which means the door to the stomach, it stays locked.
And then the second problem is that the main part of the esophagus, the tube itself, it can't do its job either.
That's the second failure. The esophageal muscle lacks proper peristaltic activity. Peristalsis is that wave-like contraction that pushes food down. So what you have is a tube that won't squeeze, trying to empty into a door that won't open.
The result for the patient is just, well, severe dysphagia, right? Difficulty swallowing.
Yeah, and food and saliva just build up. When an endoscopist goes in for a look, the esophagus is often widened, it's full of stagnant material, and that lower sphincter is visibly tight, almost beaked.
And that diagnosis immediately tells you what the goal of any treatment has to be.
It does. Since the muscle is locked in spasm, the only effective long-term treatment is to relieve that spasm by, and this is key, intentionally disrupting the muscle fibers.
So you have to cause a controlled injury.
You have to. A controlled muscular injury to restore function.
This brings us to the context, then. Before we get into the weeds on the pneumatic balloon, we should probably touch on the main alternatives that share that same goal.
Good idea. There are two other major approaches, surgical and advanced endoscopic. The surgical one is called a myotomy, where a surgeon uses a laparoscope to go in and just directly cut those tight muscle fibers.
And then there's the really advanced one.
That's POMM, per-oral endoscopic myotomy. It's an incredible technique where the endoscopist creates a tunnel inside the wall of the esophagus, cuts the muscle from the inside, and then closes the tunnel on the way out.
Both of those sound incredibly precise. Targeted cuts. Which raises a question for me. If POM is so modern and surgery is so definitive, why would anyone still rely on pneumatic dilation? It sounds, a bit like a brute force method in comparison.
That's a critical question, and it really speaks to the balance of clinical practice. While POM is revolutionary, it needs very specific, highly specialized training and equipment. The long procedure.
So it's not available everywhere.
Not at all. And for a patient who might be frail, or for a hospital where that expertise isn't local, pneumatic dilation is still incredibly valuable. It's faster, it's often cheaper, and it provides excellent immediate relief, even if it might need to be repeated years later.
So it's about accessibility and efficiency.
Exactly. The goal is the same disruption, but the mechanical path is just different.
Okay, so let's unpack the mechanics of this thing. How is it so fundamentally different from a typical balloon dilation you might use for, say, a stricture from acid reflux?
The differences are profound, and they're rooted in physics. The first one is right there in the name, pneumatic. Regular dilations use water, a hydraulic system.
Right, saline or water. But this uses air. Why is that specific choice air so vital when you're trying to break muscle?
Because air is far less compressible than water. When you inflate a balloon with water, the force is more, expansive and elastic. It's designed to gently stretch and remodel scar tissue.
But with air.
When you inflate a balloon with high-pressure air, the resulting force is rigid. It's firm and decisive. And that rigidity is what allows the balloon to exert a shearing force, which is what you need to actually tear and rupture those spastic muscle fibers. That is the entire objective.
Wow, okay, that's the core mechanical difference. So what's the next one? The delivery system, I imagine.
Yes. The system is just too large. It's too stiff and wide to pass through the working channel of the endoscope like smaller balloons. This means you need a totally different setup.
So the guide wire goes in first. Dr. Raju mentions using a savory wire. What exactly is that?
A savory wire is a specific type of guide wire. It's significantly stiffer, more rigid than a standard one, and that stiffness is vital because once you take the scope out, that wire is the only thing maintaining your access. It's your rail.
And the heavy pneumatic dilator needs a strong track to follow.
It does a strong, steady track to slide down over. The saver wire provides that firmness all the way into the stomach.
So the Savory wire is secured, and then the scope comes out completely. The endoscopist is now essentially blind.
Exactly. The pneumatic dilator is then passed over that guide wire, and the entire procedure, positioning it, inflating it, all of it, has to be done under fluoroscopic control.
Real-time X-ray monitoring.
That's it. You lose the up-close camera view,
Yeah.
and you have to rely on the anatomical landmarks you can see under X-ray.
Let's talk about the risk factor that the sizes imply. Standard stricture balloons have a huge range, right? Like 6 millimeters up to 20.
A very wide range, yes.
Yeah.
But the pneumatic system is much more limited.
Very limited.
It is. These pneumatic balloons only come in 3 sizes, 20 millimeters, 30, and 35. That narrow range really highlights the aggression of the tool. That jump from 20 to 30 to 35 isn't gradual stretching, it's exponential disruption.
And the source material is crystal clear on this. Those larger balloons directly correlate to a much higher perforation risk.
Absolutely. The 35 millimeter balloon is the highest risk tool in the kit. It causes the most dramatic disruption, which is good, but it's also significantly more likely to cause a perforation, a hole.
Which is why there's a protocol.
There is. You almost always start at 20 millimeters, you escalate to 30, and then maybe to 35, only if the patient has persistent symptoms. It's a risk calculation every single time.
That clinical decision-making is fascinating.
Ah.
Okay, let's walk through the procedure itself. The patient is asleep, the wire is ready to go, scope goes down first.
Yes, first the endoscopist makes sure they can get the scope cleanly into the stomach. They confirm the pass is clear. Only then do they deploy the Savory wire, usually aiming for the antrum.
The antrum being the lower muscular part of the stomach. You want the wire seated firmly there so it doesn't pull out.
Correct. So the wire is carefully inserted. As the endoscopist pulls the scope out, they feed more wire in, making sure at least 3 markings, about 6 centimeters, are always visible outside the patient's mouth. That gives them maximum stability.
And once that wire is secure, the big pneumatic catheter gets loaded on.
Right. It's lubricated, loaded onto the wire, and then slid down until it reaches the area of interest.
Which is the GE junction, the gastroesophageal junction.
Exactly where that spastic LES is located.
Yeah.
And now, fluoroscopy starts. The lights go down, and you're watching the shadow of the catheter on the monitor.
What are they looking for? What's the key landmark?
They are looking for the waist. When the deflated balloon is positioned across that tight muscle, the muscle squeezes it, creating a little hourglass shape. That narrowest point is the waist.
And that waist has to be perfectly centered.
Perfectly, right across the spastic sphincter, because that's where you want to apply the maximal force. Once the endoscopist is happy with the position, inflation begins.
This is the moment of truth, then.
It is. This is the technical climax. They pump air in, watching the screen, and the critical visual cue for success is seeing that hourglass waist snap open, disappear.
And when that happens, you know the muscle fibers have ruptured.
You know the disruption has occurred. The high-pressure, rigid air has done its job.
But they don't just pop it and pull it out. It stays inflated for a bit, right?
It does. There's a measured time. It varies, maybe 30 seconds, maybe a full minute. It's a carefully timed wait to maximize the effect. Once that time is up, the balloon is rapidly deflated.
And then the whole apparatus, the balloon catheter and the Savory wire, they're removed together.
And the procedure is mechanically complete. But, and this is a big but, the immediate work is not over.
Because you just intentionally ruptured tissue.
And that carries the primary risk we've been talking about, perforation. So post-procedure safety is paramount.
What are they looking for in the recovery room?
Acute escalating pain. That is the classic warning sign of a perforation, a hole leaking content into the chest. And because this risk is so real, just monitoring isn't enough.
The contrast study is mandatory.
It is. The patient swallows a contrast liquid, and under X-ray, if there's a leak, you will see it. Without a clean contrast study, the patient is not going home.
But if it's clean, they can be discharged, I assume, with some very specific diet instructions for the next few days.
Exactly. Allowing that site of intentional rupture to begin healing safely. It's a fine line, isn't it? Achieving enough muscle damage to relieve symptoms while avoiding a life-threatening complication.
This has been a deeply detailed look. What we really learned today is that pneumatic dilation isn't just standard stretching, it's enchilon trauma. It demands the rigidity of air, not water, and the navigation of fluoroscopy, not a camera.
And it really underscores that even with all the advanced technology we have, Sometimes a powerful, well-applied mechanical solution is still a highly effective and necessary tool for these complex disorders.
It makes you think, though, if we connect this to the bigger picture, we learned the 35 millimeter balloon carries the highest perforation risk. So how does a doctor navigate a partially successful procedure? Say the patient only gets 50% relief from the 30 millimeter balloon.
That's a tough spot.
Right. How does the necessity of bringing them back for a riskier 35 millimeter procedure influence that patient's anxiety and their willingness to even return for more treatment? That patient element, it has to factor into every single clinical decision.
That's a vital point to consider. It's never just about the technical success, is it? It's about the patient's entire journey.
Thank you for sharing the source material from Dr. Raju and for joining us on this deep dive.
My pleasure. We appreciate you engaging with the material.
We'll catch you on the next one.